And now we'll move on to another presentation by Dr. Sujoy Pal, and he would show a video on SMA first approach with SMB resection in pancreatic duodenectomy. Dr. Sujoy.
Good afternoon, sir. Thank you for the introduction. I'll be essentially presenting a video on the SMA first approach and also discuss the SMV resection in a separate patient. We could not have the same video in the same patient. So the case was a standard periampullary carcinoma, 52-year-old lady presenting with jaundice pruritus for 2 months, had loss of weight and anorexia, had undergone a ERCP and stenting, which is a common thing which happens nowadays. The patient had good general condition, and when she presented to us, the bilirubin was acceptable. On the CT, there was a bulky ampulla. The IHBRD was still dilated, CBD was dilated, and MPD was prominent. And the MRCP confirmed the same. And there was a bulky friable growth in the D2, although the biopsy only showed dysplasia. We could not confirm the malignancy pre-op. So the video is working when I went to the preview room. Go back to the raw videos, not to the embedded ones. So this is the video of the CT scan which shows the dilated IHPR. You can trace the CVD almost to the ampulla. And you can see that the MPD is prominent in the head and the neck area. And the duodenum is obviously filled with the ampullary swelling. So moving on to the technique, we have to do an extended cauterization, where we have now the IVC is laid bare, and you can see that the left renal vein has been taped with the blue sling. Then you have to dissect around that area in the perivascular adhesions and the lymphatics around the root of the celiac, the SMA artery, which can be palpated just above the left renal vein. So I have used a harmonic here to dissect some of the lymph nodes around the root of the SMA before we actually reach the SMA. The SMA is actually, the artery appears very thick because of its perineural connective tissue and other lymphatic tissues which are often there. And here I have been able to hook the SMA with a red tape. So this is the approach that I most commonly use to identify and hook the SMA, which is a supraduodenal or the supracolic posterior approach. Often I am able to complete the SMA dissection and the peri-adventitial dissection in this fashion to liberate the uncinate process from the medial contact with the SMA by using this technique. But sometimes I have to use the uncinate process approach also to complete the entire mobilization of the SMA off the uncinate process. And here you can see the dissection is proceeding in that area. There may be small vessels which can get disrupted while you're dissecting, but that has to be ligated. And you can encounter the IPDA, or the inferior pancreatic duodenal artery, in this phase of the dissection, going into the uncinate process, and you can ligate it if it is easily identifiable and seen from the dissection from the posterior aspect. You notice that the assistant has to pull up the duodenum vertically, so the head is also lying vertically, and that stretches out the SMA and helps you with the periadventitial dissection that you have to do to liberate the tissues around it, so that the uncinate process area is liberated from the SMA in its entirety. Can I have a pointer? Now I've moved to the, which one? This one. I moved to the anterior aspect after opening the lesser sac, ligating the tripod vein, and liberating the gastroepiploic vein, the right gastroepiploic vein, from its entry into the SMV. After doing that, the SMV becomes clear, and the other inferior pancreaticodural veins are individually ligated to liberate the middle aspect of the SMV. And we carry on the dissection in a deeper plane to get access to what I call as a window, which is between the portal vein on the left side, the margin of the uncinate process of the pancreas on the right side, and the inferior part of the D2, D3 area of the duodenum in the inferior aspect. So that window is liberated, and often the only structure which crosses that is the IPDA, or the inferior pancreaticodural artery, if it has not been lysed before. Sometimes the dissection here can become tedious, especially if the veins draining the D3 into the first jejunal vein get disrupted when we are trying to pull the duodenum excessively. At that point of time, they might, because of traction, they might get disrupted. So you have to be careful here in this part of the dissection so that the vein is not damaged. So here is the IPDA which has been divided. The IPDV has been decided. This is the window which has opened up and which is in communication with the posterior dissection that you have done. And you can see the SMA which is lying posterior to the superior mesenteric vein. This is the superior mesenteric vein, and the SMA is here, and you carry on the dissection here. So a combination of so here you can see that the duodenum has been lifted anteriorly, and you can see that the red tape which is on the SMA, and the uncinate process has been liberated from the SMA. Further dissection will clear out all the other connective attachments here. And once that is done, this is the final view where you can see that I often sling the SMA from above also near the uncinate process and take it down. So you can see the entire SMA which has been hooked, and this is the SMV portal vein which is going up. That's the uncinate process which has been liberated. Now the IPDA which is identified was secured. So that is the final part of the dissection of the SMA and the SMV. Now the one thing that I want to emphasize here is that since you can do this part of the dissection, you'll not be able to see the SMV that clearly in the posterior aspect in those tumors which is engulfing the SMV but not engulfing the SMA. So this is after the resection in this particular case. So that stage, which I wanted to stop but I could not stop the video, where you can see the artery and the SMV separately, is actually the place where you make the decision to clamp above and below in a patient who has a tumor which is infiltrating the SMV, so that you can minimize the clamp time, remove the tumor, and you don't have any further attachments to tackle. So moving on to the next video. I don't seem to get the cursor here. This was a 66-year-old man who had a Can we enlarge? This was a 66-year-old man who had a tumor infiltrating the SMV. Here you can see I'm trying to dissect the SMV and the inferior pancreaticoduodenal vein before applying the clamps in the lower aspect and the upper aspect here. This patient had received FOLFIRINOX 8 cycles and thereafter came in for the resection. He was borderline resectable before the starting of the neoadjuvant and remained so on imaging even after completion of his NACT protocol. So we went ahead and since it was just the vein which was involved, not the artery, we were able to take away a segment of the vein after having taped. The blue sling above you see is in the upper part of the portal vein, which has been slinged and taped away. In this video clip, you'll see suddenly there is a rush of blood, which is probably because the IMV, which was not slung, started bleeding, and that was secured later. So after having secured that bleeding, we went ahead with the anastomosis. So we have to dissect the lower edge of the SMV from its attachment so that we have enough length for a good anastomosis. You can see that the distance is almost about an inch, around 2.5 centimeters, but we are able to approximate this after doing the anastomosis. So this is the beginning of the anastomosis. The corner stitches are being taken. Sorry for the shaky video. It was a handheld video which was taken. And similarly, the other corner towards me was taken. Usually the clamp time when you have done a SMA first approach is around 15 minutes for the SMV resection and anastomosis. Here we are continuing the anterior wall of the anastomosis. And once that is done, we usually liberate the proximal clamp on the SMV first so that the slack in the suture line is taken up and any leaks are identified before opening the distal clamp so that the portal vein is back into the system. The last stitch being taken, clamps being released. So that's the end of this video. So this is the kind of appearance of the reconstructed SMV and the portal vein. This is spinning vein draining into it. And we've just presented our data at the IHPB meeting in which where we presented our data in the randomized trial which we conducted between the SMA first technique and the classical pancreaticoduodenectomy technique, where we compared 90 patients who underwent the SMA first PD with a classical PD of 93 cases. We could not demonstrate any difference as far as the operative parameters are concerned. For example, the blood loss, the operating time, the early post-operative complications were also similar. Clavien dendo grade 3 complications were also similar. As far as the R0 resection rates were concerned, that also turned out to be similar. And the long-term and the medium-term survival and recurrence-free survival were also similar. So what we began with the hypothesis thinking that a posterior SMA first approach would end up yielding a better R0 resection was not established by this trial. It could be because a major component of the patients was because of periampullary carcinoma rather than pancreatic head cancers. We had 11% of cases who were pancreatic head cancers, but large majority were periampullary. Maybe that is the reason why we could not establish that the R0 rate and the recurrence-free survival wasn't any significantly different. But I think this is what the current literature is saying about the SMA first approach. But overall, I feel it's an elegant approach and it should be doable. And whenever you have preoperative doubt that the SMV might be infiltrated, it is quite an elegant approach to decrease the clamp time and allow a safe resection with vascular reanastomosis. I end my presentation here and I open it for discussion. Thank you.
Thank you, Dr. Sujoy. It's a lovely video and also your data giving and summarize the outcome of the surgery. Any questions from the...
Yes, sir, it's a part of a protocol. It's a part of a protocol because it was this case was part of this trials.
Please.
Dr. Sandeep Chakravarti from Kolkata. I just want to ask you, what about the tumors of the uncinate process? How do you approach? The same way, the SMA first?
Yeah, the SMA first remains the same.
Right. Even with the uncinate process tumor?
Yeah. As I said, I can switch between the posterior approach and the uncinate first approach. And sometimes we can go ahead and also mobilize the first part of the jejunum and bring it towards the supracolic compartment to help aid in the last part of the resection.
Please, yeah.
Please. So, sir, what I wanted to know is when you are doing SMA first and when you are not doing SMA first, does your plane change?
Does your?
The plane of dissection change. So, for a pancreatic cancer,
that was my hypothesis that it initially when I started it, but with the experience of SMA first, when you revisit classical, you end up doing the same dissection.
So, for example, if you are following a standard LV2 dissection for periams and maybe LV3 or LV2, depending upon the extent of the tumor in uncinate for pancreas, if the plane of dissection is going to be the same and if the tumor is operable, ideally it should not make a difference, and that's what probably you
but as I said, I qualified that statement by saying that we are dealing, this majority was periam, you know. Yes. If we had CA head pancreas, maybe, we don't know.
So probably what I wanted to focus on was that the plane of dissection needs to be stressed.
Standardized
and
and
probably
stressed.
Saying that you have to...
Whether you do classical or SMA first, probably doesn't matter.
Yes.
But I do find it as a very elegant method of doing
so
it.
dissecting of the SMA first, as you said correctly, reduces the clamp time, and hanging the tumor on the vein is really a classic technique. But the plane of dissection doesn't change, and that's probably the reason why you also didn't find out the difference anyways.
Please.
Yeah. So you clamp the portal vein above and below, and then divide the tumor with or without a part of the portal vein as required. Would you not routinely also sling the splenic vein?
Yeah, in this, the upper clamp was in such a way that the splenic vein and the portal vein were together in that clamp. If you see, you could see the carina.
Would that not be the clamp that would therefore make mobilization more difficult? Whereas if you were to
did not find in this particular case, yeah, it can happen. Then you need to dissect the splenic vein also at that point.
Thank you, Dr. Sujoy.